We have a wonderful hour and 20 minutes coming our way right now because we have, am I still on? I am. Dr. Fine is here with us today. You see, you already have fans. Luke's already a fan. Wow, this is impressive. So as people are filing in and sitting down, I really think this is a special part of our term because this is an opportunity to have a bit of a sneak peek into a specialty that not all of us have the opportunity to learn more about in our future careers. And it's also a wonderful time to actually see some footage of procedures that I know you've heard about and I know you're aware of currently. And I think that's really one of the fantastic pieces we have here today. So I hope you'll settle down and get into your seats and get ready to go. And then we'll introduce Dr. Fine. The piece that's always outstanding to me when I think about Dr. Fine's bio is that he was mentioned as one of the top 25 most influential ophthalmologists in the world. Wow, I know. And so I feel like we're really honored to have him be interested in education to the degree that he would take time out of, I can't even imagine the busy schedule, to come and talk with us today. So this is a really fantastic opportunity. Let's take advantage of it and let's welcome Dr. Fine to the front.
How's that? Am I on? Can you hear me, folks? Good.
Can you hear him in the back?
Can you hear me all right? Can you hear me? You know, I was a drill sergeant in the Army. No one ever said they couldn't hear me. How many people here are going to be doctors? How many are going to be dentists? How many are going to be nurses? Physical therapists? Lawyers? Boo. Good deal. Well, you know, you never know where you're going to end up. I did my undergraduate work at MIT, and I worked as an engineer, and I found I didn't like it. So I did laboratory research, and I found I loved it. And I thought I'd go to medical school because I would have better opportunities for laboratory research than PhDs, and I found I loved clinical medicine. And while I was in medical school and specialty training, I did a lot of teaching of medical undergraduates, and I found I liked teaching. So I found I like engineering, I like medicine, I like teaching, I like research. So I do them all now. Our practice is divided between approximately 1/3 clinical research, 1/3 patient care, and 1/3 teaching. And I really like teaching undergraduates because you have the longest time to utilize what I tell you. So this is a course in anatomy and physiology. Is that right? Or is this the French film course? Which is it? Anatomy, okay. What we're going to talk about today is the anatomy of the eye, and most anatomy courses don't even deal with eye. And we're going to show you how anatomy and physiology are used to advantage or are changed by surgical procedures in order to either reestablish a state of health or enhance function. Okay? So we're going to look a little bit at the anatomy of the eye. This is familiar to all of you, isn't it? The cornea, whoops, this is, I got to do this, yeah, I got to take a lesson in how to work this equipment. This is a picture of the eye, and the eye is basically a fluid-filled sphere, and it's thought of as being containing 3 coats. The outer surface of the eye consists of the cornea and the sclera. The cornea occupies about 1/5 of the circumference of the eye. What's different between the cornea and the sclera when they are made up principally of collagen? The cornea is transparent and the sclera is opaque. Well, how can that exist? How can that be? They're both almost 99% collagen. That's true because the corneal collagen, which are long-chain molecules, proteins, are all lined up parallel to the surface. Okay? And in sclera, there's a randomization of molecular orientation. So if you think of a Venetian blind, if you line all of the slats up so that they're parallel to the floor, you can see out of the window. Is that correct? But if you just put them all on top of the window with random orientations, you'd probably obscure the view. Okay? One of the things that we worry about is that in healing, the cornea can be changed from clear to opaque as a result of randomization of molecular orientations in the fibrosis and healing that takes place. So we're always protective of the cornea. Just under the cornea is a fluid-filled space. What is that called? Anterior chamber, correct. And at the base of the anterior chamber is this circular structure with a hole in the middle called the pupil. And what do we call that? The iris. And the iris is colored in most people, and we describe people as having blue or green or brown eyes, and that's based mostly on the pigment on the undersurface of the iris. And just continuous with the iris is a circular structure. It comes around that is called the ciliary body. Have you heard of that before? The ciliary body suspends the lens, and this is the crystalline lens, which is almost completely proteinaceous and is dehydrated. It suspends it by tiny ligaments called zonules. The lens is clear and transparent, and so is the cornea. Okay? And then continuous with the ciliary body is the middle coat of the eye, the choroid. So the outer coat is cornea and sclera. The middle coat is iris, ciliary body, and choroid. The ciliary body suspends the lens and has one other very important function. Can anybody tell me what that is? What does it do? It does contract and relax, and that changes the contour of the lens and allows us to focus. Is that correct? But if you think about the fact that this structure and this structure, the cornea and the lens, are both living, okay? And they're transparent, and they have no blood vessels, because if you put blood vessels in them, they would no longer be transparent. In fact, one of the ways in which the cornea opacifies is in diseased states, blood vessels can grow into it and it turns opaque. So how do they get metabolites? How do they get nourishment? Does anybody know? Aqueous. And where does the aqueous come from? That's correct. The inner layer of the ciliary body, the ciliary epithelium, produces a nutrient broth called aqueous humor. And aqueous humor flows around the lens, supplying metabolites to the lens, because the lens is growing throughout life, goes through the pupil, fills the anterior chamber, and goes through the cornea as well, delivering glycogen and other important substances to the cornea. So this is the way in which these two structures, which are avascular, are able to live and grow and metabolize. And then finally, the inner coat of the eye is the retina. And the retina has the light-sensitive structures in it, has the perceptive structures, the rods and the cones. And the retina is contiguous with and is a part of the optic nerve. And the optic nerve leaves the eye, goes back, crosses partially, and ends up in the occipital cortex, where interpretation is made of the electrical stimulation of the retina by light. And that's how we see what we see, and that's how the images that are conveyed by light are interpreted by our brain. Okay, so once again, this is ciliary epithelium here, this yellow stuff. Okay, this is ciliary muscle. It's responsible for contraction. And the fluid that is produced by ciliary epithelium and surrounds the lens and fills the anterior chamber and goes through the cornea is principally drained by this junction between the iris and the cornea, which is known as the anterior chamber angle. Okay? And it is conveyed through a system of ports or openings to a structure known as through this system, which is called trabecular meshwork, to a canal, which is called Schlemm's canal, and then from Schlemm's canal, it is drained into veins that are on the surface of the eye. So what you have is a closed system. The heart beats, blood is sent to the ciliary body. Out of the blood, ciliary epithelium elaborates aqueous humor, yes? Aqueous humor is poured over the lens and fills the anterior chamber, goes through the cornea partially, is principally drained here, goes into the venous system, and is returned to the heart, where we repeat the same cycle, okay? Now, if we think about the way rays of light are focused, they're focused principally by the cornea. Okay? Is that a surprise to you? Yes, it is. You're looking at me and wondering what I'm talking about. They really are bent by the cornea. Most people think that the lens focuses rays of light, but the human lens is really a zoom. If you think of a zoom on a camera and you're focused for the distance and you want to magnify it, you zoom in, but the focus is still in focus. Is that correct? So the lens is really for focusing from distance to near, but it is the cornea and its curvature that determine how the rays of light are bent so that a focus comes either to the retina or an out-of-focus image comes to the retina. And this is the principal refracting surface in the eye. Now, oops, I'm going the wrong way again. So we'll start, wait, just in a second. So let's do one other thing. Let's talk about the fact that if the cornea is a very steep structure, that is to say, if it's very steep like this, it's going to be sort of like a strong magnifying glass. Is that right? If you think of a magnifying glass, it's very powerful. It has a big curvature. Is that correct? If the cornea is very steep, the rays of light may be focused in front of the retina. Does that make sense? Does it not make sense to anyone? So what would happen if the rays of light were focused here? What would the retina see? Out of focus images, because the focus would come here, and then what came to the retina would be out of focus light. It's very similar to taking the screen from a slide projector and moving it back 2 feet. It's in focus, you move it back 2 feet, what do you see? Blur. Okay? On the other hand, if this is very flat and doesn't focus rays on the retina, it may have a focus that really is behind the retina. And that's equivalent, really, to taking a screen from a slide projector that is in focus and moving it toward you. What would you see then? Again, blur. Is that correct? Now, what do we call it when the rays of light are focused in front of the retina from a steep cornea? Does anybody have an idea? Right, nearsightedness. And it's nearsighted because images closer to the eye will be in focus, but distance images will not. Okay, and the reason for that is that images coming from closer are bent in this way, and they don't have to be bent as much to fall on the retina. What do we call it when something is focused behind the retina, when the cornea is either too flat? Farsightedness, okay? So we have two situations, nearsightedness and farsightedness. One of the ways that farsighted people, yes, please, ask your question.
On your website, you guys say that like nearsightedness or farsightedness is from the eyeball either being too short or too long.
Right.
Is it actually? I mean, do you just say that so it's easier for?
No, that's actually accurate. So we're going to get to that. So it can be either. So if you had a very flat retina and the light was focused behind it, if the eye was actually bigger than a normal eye, it might be in focus. Is that correct? By the same token, if you had an eye that was very short and a steep cornea, a nearsighted situation may not exist because the steep cornea bends the rays of light more, but if the eye is short and the retina is closer to the cornea, it might be in focus. Is that correct? Does it not make sense? Yeah. There's one other refractive error. What is that called? Astigmatism. Does anybody know what astigmatism is? Astigmatism is a situation that exists when the curvature of the cornea is not spherical. It's toric. And toric means that the surface is constructed in such a way that in one direction the curvature is steeper than in the direction 90 degrees away. So if I took a squash ball and I squeezed it, the curvature this way would be steeper than the curvature this way. Is that correct? That's the situation that exists with astigmatism. So we can have nearsightedness, farsightedness, and astigmatism. Now, what can a farsighted person do to see better? on his own. He can zoom. Okay? We said that the far-sighted cornea is generally flat, or the eye is short. But one of the things that the far-sighted person can do is he can focus with his lens. He can accommodate and then see well. So one of the differences between far-sighted and nearsighted people is the far-sighted kids don't even know they're far-sighted. They're eagle eyes. But as we get older, what happens to the lens? It becomes less elastic, and as we try to focus, it doesn't respond. So the eagle-eyed kids can't see very well when they start to get around 40 or 45 because they can no longer focus, okay? Nearsighted people, what do they do with their lens to see as well as they can? Well, they can squint because it creates a pinhole, and when you create a pinhole, all of the rays of light are central rays, and those are always in focus. When you think about it, rays coming from different directions here are bent depending on where on the curvature they are, but the central rays are always in focus. So by squinting, a nearsighted person can see well. But can they adjust to their nearsightedness with the lens? No. The only thing that they can do is let go. If they focus at all, their vision gets worse. So they have to relax accommodation, okay? So let's take a look at what we can do to the surface of the cornea to enhance vision. Yes? What am I? I'm presbyopic. You know what that is? What is it? The lens is old. It's big because it grows throughout life. It's less elastic, so when I focus, the lens just sits there. Okay? So I can see perfectly like this in the distance, but when I put my glasses on, I can't be sure it's my wife I'm kissing. So I wear glasses almost exclusively to see up close. Okay? And we're going to talk a little bit about that later. So what could we do to the cornea, the principal refracting surface of the eye, to help a nearsighted person, assuming that they have a normal axial length and a steep cornea? What could we do? Change the focal length. How are we going to do that? But we can't do that. We can't do that, really, can we? So what we can do, what were you going to say? I know you have it. Yeah. Huh? Widen it. What does that mean? Yes, but that's not really widening it. Her answer was widen it so it's less steep. What you really mean is flatten it, and that's exactly right. So what we can do in a nearsighted person is flatten the surface of the cornea, and we can flatten it exactly the amount necessary for the rays of light to come into focus. And for a farsighted people, what could we do? Steepen it. And we can do that by cutting with a laser grooves here and here, a circle of grooves around the center so that the central curvature is even steeper. Okay, so I think let's show the video. And we're going to show you videos. Is anybody going to get ill here? I brought a couple of techs. They have a stomach pump. Should you want to introduce? Just look away. Okay. I think maybe, can we turn the lights down? Here.
Excuse me for a second. Jade, if you're downstairs, or Lynette, would you come up and help us with the video? Thank you very much.
Is there someone in? Do we have to turn this off, Sherry, for that?
So it should allow us just to toggle. So let's go to VC.
Combines the computer-controlled precision of the excimer laser with the rapid healing benefits.
All right. Okay, I think it may help if we turn the lights down. There it is. There it is. It's okay. Let it run. Let it run. Let the sound. Yeah, yeah.
Keratoplasty. With LASIK, a flap is made in the outer layers of the cornea at about 25% of its depth from the surface with an instrument known as a microkeratome. The excimer laser then sculpts the internal corneal tissue to the correct refractive power of the eye. The corneal flap is then replaced in its original position where it bonds without the need for stitches. Now, how does PRK compare to LASIK?
Place the speculum after the drape is in place. Continue to give the patient anesthetic drops.
Are you okay?
A corneal reference marker is used to make a 10 millimeter...
See, this is just a marker, so you can always be sure of the corneal orientation. You see it puts...
The next step is to place the automated corneal...
Can you hear the audio?
The corneal flap.
Turn the audio off.
Position the suction ring...
This is the microkeratome, and it's going to cut a flap. It's very precise in the way it works, and it's applied to the eye, and suction is applied, so the eye is held firmly. And then the microkeratome is put on the track, and it will automatically drive across and back, and it will cut a very thin slice of cornea, not full thickness cornea. And then we release the suction, and we can lift the flap. You'll see we're going to take this ring and its entire apparatus off. That's the way it looks from the side. And then we'll be able to lift that flap, as you'll see here. It'll lift right up. Yeah, the person's awake and their eyes open. They're looking right at it all. So you see? And now we're going to turn the laser on, and the laser will ablate corneal tissue by essentially vaporizing it. It's going to break molecular bonds. You can write your name on a human hair with the laser. It's so precise, and you'll see it. You'll see smoke coming from the cornea. You can see this blinking light. And you should be able to see a pattern of flattening happening here. So the laser light is invisible. Okay? And we tell the patient, watch your refractive error go away. There's the laser. It's pulsed. You see, this area is getting flatter here. It's bloodless. That's right. Isn't that nice? Yeah. You know, an ophthalmologist is a doctor who faints at the sight of blood. And now we just have to put the flap back. And that's it. And the flap will stick on its own. And the reason that it sticks is that the inner layer of the cornea cells have a pump-like mechanism that pull water and salt out of the cornea. And it does that to keep the cornea thin and compact and clear. And so that endothelial pump acts like a vacuum that sucks the roof of the flap down onto the base of the flap. And you can see it's tight. So we don't have to suture it. Okay? I'm sorry, say it again. Yeah, it takes about 4 or 5 minutes per eye. Yeah, it's very fast, very fast. All right. Yes. It does, yeah. The question is, does the cornea get sucked into the slicer? And the eyeball, when the suction ring is applied, protrudes through the opening in the ring. And so the cornea is relatively flat at that point, and it takes a calibrated amount of corneal tissue away. Yes. LASIK is probably 18, 20 years old now. Yeah, it was. Okay. Now, questions? Yes. We'll get there. Back of the eye. No, Just eye drops. We just give topical anesthesia. The patient's awake. The patient can see the entire time. No. No. Other questions? Well, you see, it takes a little bit of effort to lift it, but you've already had a blade go through it, so some of that bond between the layers of the cornea is disrupted by the cutting. But you can raise that flap sometime later, but it's hard. It peels off as though it's a stamp stuck on an envelope. Yes? No, there's not really pain. You know, people aren't that motivated to get rid of glasses that they'd subject themselves to discomfort. The eye drops take away all of the pain. Yes? Yes?
How thick is the cornea?
The cornea is about half a millimeter thick in the center. Somewhere in the neighborhood of 200 microns. Yes? Well, when the ring is on, they can't move their eye. And we're holding a handle that's attached to the ring, so they can't. And then the laser itself has a tracking device, so if they move their eye, the laser will shut off. And they're looking in the laser at a target light. The laser light itself is invisible. Other question, yeah?
There's a question
In Bend, yes? No, that's not true. That's not true. The sclera is very soft. The cornea is like grizzle. Sclera is very soft.
What's the tough part of that? It's not sclera.
Well, the cornea is a lot thicker, and it's more compact. The question was, why is the cornea tougher than the sclera? I think, you know, in some animal eyes, it may be that the sclera is tougher, but you can bend the sclera. We use donor sclera and donor cornea, and there's a huge difference in the toughness of them. The sclera. Not in human eyes. Oh, sheep eyes. Bah. You got me there. One more question.
Do you do the same procedure for cataracts and astigmatism?
Nope. No. For astigmatism, we do. And you think about it, if the cornea is toric so that it's steeper in one direction than in the other, we can flatten it in that one direction. Does that make sense? Yeah. One last question. Yes?
How much error is involved in a procedure like that?
How much error is involved? Sure, because nothing is perfect. But the machines are standardized and calibrated, and there are multiple checks and balances in the operating room, so we make sure we have the right patient, the right eye, the right refractive error, the right fluence, because it's a big no-no if you make someone more nearsighted when they're done than they came in with. Yeah.
What do you use the donor cornea for?
Corneal transplant, mostly.
Just like, what kind of?
Opaque corneas. Okay, we better move on. All right, we're going to talk a little bit about glaucoma. Do you remember we said that the lens and the cornea are transparent? The cornea is compact and thin. It's dehydrated by the inner surface of the corneal endothelium. And the lens is almost anhydrous. It's almost completely protein. And those are nourished by the ciliary body elaborating aqueous humor that flows over the eye, through the pupil, fills the anterior chamber, and nourishes the cornea as well. But most of the aqueous humor is drained through the trabecular meshwork into Schlemm's canal, and then it eventually is returned through the drainage system to the aqueous veins on the surface of the eye. Now, let's ask a question. Suppose the rate of formation of aqueous humor is more rapid than the rate of drainage. Does that make sense? It's possible, isn't it? Okay. What would happen? The eye would get hard. Isn't that correct? If you're blowing into a balloon that has a little leak and you're blowing faster than the air is going out of the leak, the balloon will blow up. It'll inflate. Okay? So if we have, for any one of a huge variety of reasons, an imbalance between formage and drainage of aqueous humor, we get an eye that is firm. And what is that called? Glaucoma. That's correct. Now, that's a very simplified view of glaucoma. Okay? But if the eye is firm, it can compress the capillaries that feed the optic nerve. Okay? And if that happens, they compromise the nutrition of the optic nerve, and the optic nerve will start to atrophy. And glaucoma can lead to blindness. So what we have to do in glaucoma is either decrease the formation of aqueous humor, and we have medicines that will do that. Okay? We have medicines that will interfere with metabolism of the ciliary body so aqueous humor production is decreased. Or we can have other medicines that increase the drainage through the trabecular meshwork of aqueous humor. They facilitate aqueous outflow, and we have other drops that do that, or we can use combinations of them, okay? Now, there are several types of glaucoma, and I don't want to burden you with the whole picture, but you can look at it as an imbalance between inflow and outflow. And in a particular eye, when that imbalance exists so that the capillaries to the optic nerve are compromised, the optic nerve is at risk. And I said we have medicines and we have surgery, but we're going to look at one other thing here, and that is in certain circumstances, either anatomic, surgical, traumatic, a whole bunch of things, the angle here can become sufficiently narrow that the iris falls against the trabecular meshwork and disallows drainage. Okay? And one of the ways that can happen is if the lens grows sufficiently and gets thicker and thicker and thicker as we age, and the patient already has a small eye, it may crowd the anterior chamber angle. Okay? And that creates a situation that is called angle closure glaucoma, and that is a surgical emergency. That has to be addressed. And the way that we address that is we put a hole in the periphery of the iris here. And we do that today with a laser. We don't have to open the eye. We use a laser. We put a hole. That way, if the peripheral iris is up against the trabecular meshwork so that fluid can't get in there as it goes through, that will reestablish a space and allow for drainage. Does that make sense? Now, what are some of the other ways that we may be able to treat glaucoma? Can anybody think of another way? Yes? Yep. Well, the symptoms for glaucoma, she said, if it's open-angle glaucoma, chronic, common garden variety glaucoma, the patient usually doesn't feel anything. And that's why it's dangerous, because people can be close to blindness from glaucoma and not know they have it. That's why we check the intraocular pressure on everyone. Acute glaucoma is associated by a rapid rise in pressure that is very, very high. In fact, the patient is sick as a skunk, and they know they're sick. The eye gets so hard and so painful, the cornea starts to swell. Do you remember we said that part of the reason the cornea is clear is that the fluid is pumped out, but if the pressure in the eye goes high enough, it overwhelms the cells that pump the fluid out of the eye, and so the cornea gets opaque, so they get steamy-looking cornea, poor vision, terrible pain, and usually nausea as well. The pain usually starts as brow pain. Well, let's just look at a couple of ways that we can create an alteration in anatomy that will give us relief from an elevated intraocular pressure and allow the normal perfusion of the optic nerve. One of the things that we can do is we could decrease the formation of aqueous humor if we killed some of the ciliary epithelium. Does that make sense? It sounds terrible, but I mean it works. Okay? Another thing that we could do is we could create an opening in the eye here so that fluid flows out of the anterior chamber under the conjunctiva where it would be returned to aqueous veins. Does that make sense? No, the closed angle, all we need to do in most cases is just make the hole. But there can be damage to the trabecular meshwork. There can be scarring of the trabecular meshwork. There can be a lot of problems with the trabecular meshwork so that it just isn't going to drain fluid adequately. And so we either have to decrease fluid formation or increase fluid drainage by a mechanism independent of the trabecular meshwork. And so we have medicines that'll do both of those, but when they fail, we turn to surgical options. And we're going to take a look at a couple of surgical options. So look, we can look with a special instrument called a gonioscope. We can look into the anterior chamber angle and actually see the trabecular meshwork. And in closed angle, we can see that the angle is blocked by the peripheral iris. Do you see the difference in those two pictures? The top one is open angle and the bottom is closed angle. And one of the ways that we can create a surgical alteration in the anatomy is to to reflect the conjunctiva, make an opening into the eye, and usually we do a peripheral iridectomy as well. We cut a little hole in the periphery of the iris as well, and then suture the conjunctiva back so fluid is then flowing out of that hole under the conjunctiva. So let's show those videos. The first we're going to show is making a hole in the eye with drainage under the conjunctiva. And these are videos from one of my partners, Mark Packer, who does a lot of glaucoma surgery. So the first is called a trabeculectomy, in which we're going to make an opening into the eye so that fluid will flow directly out of the eye and under the conjunctiva. So can you see that all right? That's a cannula that's in the eye that's filling the anterior chamber with air. Now he's already got a flap dissected in sclera here. It's a partial thickness flap, and he's going to punch through it right inside the eye. That's a hole right inside the eye. Okay? And now he's going to cut a piece of the iris, the edge of the iris out. You okay, kid? Good. You got that stomach pump? And that's it. And you can tell when fluid is flowing under the conjunctiva because the conjunctiva blanches. And now he's going to refill the anterior chamber with fluid. And you may see leakage here. You can see this blanching here. So one of the things that happens when we have a well-functioning, that's called a filtering bleb. It's under the lid. The conjunctiva is white and pale, and the conjunctiva is a little edematous, but the fluid is flowing partially through the trabecular meshwork, but mostly under the conjunctiva through that bleb in the upper portion of the eye. Okay? So that's a way of increasing outflow. We create a false track in the eye, and fluid can flow out. Yes?
Is there a noticeable amount of the line just past that?
They don't have any discharge. You mean their eye? No, it's all under the conjunctiva. It's contained within the eye itself. Yes, but it drains under the conjunctiva, the loose filmy connective tissue under the eye that surrounds the eye. I'll show you again in the next diagram where conjunctiva is, okay? Now we're going to show you how we can kill a portion of the ciliary epithelium and decrease aqueous humor. So what you're going to see here, this is called endocyclophotocoagulation. This is a cataract operation that's taking place, and we'll talk about cataract surgery in a while, but we usually do this in conjunction with cataract surgery. So this is after the cataract surgery, and what you're going to see is an endoscope, a tube, like that's used for arthroscopic surgery, is going to go behind the lens and uncover the ciliary epithelium, and there you see ciliary epithelium. These are pink finger-like projections, and the way we treat them is to cook them with a laser, and when they're cooked, they turn white, just like egg white is transparent, and when you heat it, it turns white. So you can see, and we can do this preferentially. We can watch it on a monitor, and we're going to go now. He's moving to the other side of the eye to get the ciliary epithelium here, and what you'll see is this pink tissue. As he goes in, that's the endoscope going in, and then suddenly you'll start to see the ciliary processes, and they're pink, and then as he steps on the pedal, they're finger-like projections, they turn white. So what this does is it decreases the physiologic function of the ciliary body, whose epithelium produces aqueous humor, and it reestablishes a new state of equilibrium in which inflow equals outflow, and the pressure within the eye is back at normal levels. Okay, I think we can stop that. The question was, how do you know how many to do? Well, you know, over a period of time, based on what the pressure is, what the optic nerve looks like, how long the patient has had glaucoma, you can titrate it. So you can do a little bit and go back later and do more. Okay? Now, we talked about conjunctiva, and I'm sorry I didn't mention that earlier. We talked about the three coats of the eye. But starting at the edge of the cornea is a loose, filmy tissue called the conjunctiva. The conjunctiva is almost completely transparent in the healthy eye, but turns red when the eye is inflamed. So in looking at someone with a healthy eye, like this young lady, I see the sclera through the conjunctiva because I don't even see blood vessels. But with an inflamed eye, the blood vessels in the conjunctiva fill up with blood, and so we can see it. The conjunctiva goes along the surface of the eye and then is reflected on the inner surface of the lid. So if I pull my lid down, that tissue goes off the surface of the eye and is reflected on the inner surface of the lid. That's why you can't lose a contact lens behind the eye. It's a closed space. Yes?
Sorry.
There are a whole bunch of different types of glaucoma, like every disease. There are hereditary glaucomas, there are congenital glaucomas, there are traumatic glaucomas, there are inflammatory glaucomas, there are secondary glaucomas, a whole bunch of them. So heredity does play a part, and anybody who has a parent who has had glaucoma, we consider to be a glaucoma suspect. We watch them for the development of glaucoma. Yes?
There's also a high incidence among diabetic patients, is that correct?
Say it again.
There's a high incidence of glaucoma around.
It's a little higher than the general population. It's not huge. No. If you figure it out, you're going to go a long way. Okay. Now, we were talking about the lens. The lens is a structure that is living. It is continuously growing. There are cells at the equator of the lens that continuously are growing and forming new lens fibers. Okay? The lens consists of an outer structure which is called the capsule, and it's very much like the cellophane that covers a package of cigarettes. It's very similar. It's elastic. It's acellular. It's collagen. Inside that are these lens epithelial cells that produce new lens fibers that make the lens bigger as we grow. And the lens grows like a tree. The tree grows from the layer under the bark. What's it called? The cambium, right? So rings are laid down each year. You can age a tree by the rings. Is that correct? This is the way the lens grows. Just inside the lens epithelial cells is a soft material called lens cortex. And central to that is a firmer portion of the lens, which is called the nucleus. If you think of a plum, the skin is like the capsule. The cortex is a lot like the fruit of the plum, except it occupies a very thin layer. And the nucleus is like the pit, except that it's very much bigger. Okay? So as we get older, several things happen. The lens gets bigger. It gets less elastic, so attempts at focusing don't work, and by 45 we have to get bifocals. Yes? And the other thing that can happen is that its nutrition changes so that it is no longer ideally nourished, and that has to do with a lot of factors. I don't want to bore you with it here. Diabetics have a much higher incidence of cataract. It has to do with the fact that it's bigger and it requires more nutrients, that it's older, that the circulatory system that produces building blocks to the aqueous may be interfered with. And since the lens is almost completely protein and has very little water, it can change in several ways. If you take protein, which is a pure molecule, and you heat it, it will denature. And denaturation can take a variety of forms. In the lens protein, denaturation is characterized by opacification. And it's, again, not unlike egg white, which is transparent. If you drop it on a frying pan, it turns white. And all that's happened is the same protein. It's just heated and therefore denatured. And when that happens, we can't see through the cataract. So the cataract is characterized by several changes. One is an alteration in vision. As the cataract grows, the patient may become somewhat nearsighted because the rays of light are bent more. The patient may start to experience glare because the optical path through the lens isn't clear like it was, and the patient can also start to experience blurred and then finally loss of vision. So let's take a look at one way of doing a cataract surgery. What we're going to show you is a real cataract surgery in a real patient, and this is a patient that I saw 12 years before this video was made, and he had mild cataracts but couldn't drive at night because of the glare, and I said, well, I think you're ready for cataract surgery. And he said, well, I want to go home and think about it. So he went home and thought about it for 12 years, and he came back with a white cane. So you'll see that his cataract was very, very opaque, and he should never have waited that long. He did himself a disservice. You see, this is the cataract. Now we're making a small incision through the edge of the cornea into the anterior chamber. You okay, young lady? You okay? We're making a little incision, and we're going to fill the eye with a substance that's not unlike molasses. It's soft and elastic, and we can cushion intraocular structures. Now we're going to make a big incision here. Not big, really. It's really only 2.5 millimeters. 2.5 millimeters, pretty small. Remember, it takes 2.5 centimeters to make an inch. So we're talking about 2.5 millimeters here, okay? And we're going to make an undermined or shelved incision through the cornea and into the anterior chamber, okay? And right here, it's going to break through the center, the inner surface of the cornea. Now, we're going to make an opening in the lens capsule. We're going to tear a circular opening in that cellophane-like structure, and you'll be able to see it because this cataract is so old that it's partially calcified the capsule. And what you're going to see here is we're going to be making a round opening. You see how nice that tears? Got to make sure you tear along the serrated surface, huh? You can see that it's partially opacified here, so you can see it. Normally, it's very hard to see the capsule when we're tearing it because it's clear. But in this case, and we've learned how to do this, it's obviously a skilled operation, but it's something anybody can learn to do. By controlling the way in which we're pulling on that flap of tissue, we can control the shape and size of the opening that we're making, and we try for a circular opening about 5 to 5.5 millimeters. And you see the eye is very big when we're looking in there because we're looking through a microscope, so the eye doesn't look small to us, it looks huge. So we almost completed now this continuous opening in the capsule, and the thing that characterizes the capsule is its elasticity. And so that capsule will stay elastic, and because we have a continuous edge, it won't tear during the operation, okay? And then what we're going to do, this is a very hard lens, so we're going to try and take it out through that small incision by disassembling it, okay? Disassembling it. And what we're going to do, this is, first of all, we're disassembling by injecting fluid under the capsule to separate the cortex from the capsule. This is called hydrodissection. And then we're going to inject fluid into the substance of the lens to separate the nucleus from the epinucleus, the soft outer structure of the nucleus. And then we're going to use a vibrating tip that's vibrating 40,000 times a minute and has aspiration. It's a hollow needle vibrating 40,000 times a minute, and here it is, and it's got surrounded by a sleeve that is putting fluid in the eye, so the eye stays inflated the entire time, okay? And what we're going to do, did you ever eat a Hershey bar? Did you break it into pieces? It breaks easy because it's grooved. So we're going to make a Hershey bar here, okay? We're going to put grooves in this hard lens because we want to take that big white structure out of that little 2.5 millimeter incision. Why do we want to do that? Because incisions can create astigmatism, and we don't want to violate the optical properties of the eye. So here we are, we're grooving this, and this tip is literally vibrating 40,000 times a second, and you can see cavitational energy actually on top of that needle. You'll see it. It looks like a spindle, an out-of-focus spindle. And this is a second instrument that sort of controls the intraocular environment so things don't rub against the cornea, because if you rub against the inner surface of the cornea, you can disrupt that tissue that keeps the eye, the cornea dehydrated. So this has to be done very, very carefully and very precisely. If you rub against the inner surface, so we're in a very small space, we got a very high-speed vibratory instrument going on, and we want to make sure we never touch the undersurface of the cornea. So now what we're going to do is we're going to groove in a cruciate pattern, okay? And after we do that, we'll be able to split it like a Hershey bar, right? You know how you snap it in the groove? Okay, we're going to do the same thing here. We're not going to eat it, but we're going to snap it. So this tip is by cavitational energy and jackhammer breaking the nucleus and aspirating it. Okay, that nuclear sand is going down there and out of the eye, and fluid is coming out of these two side ports and keeping the eye in a steady state of inflation. Otherwise, the cornea would collapse on it, okay? So, you know, this is not something we worry about doing very fast, although anytime in surgery you like to be expeditious. You don't really want to take a long time because the eye is exposed to potential infection and other problems, and so surgery should be expeditious, but not a foot race. It's not something that we're rushing. And you can see here that I'm being very precise. Yes, you have a question?
Well, it just looks like you're like moving out the actual lens of the
Yeah,
eye.
that's exactly right.
How much are they left with?
Well, you'll see. They're going to be left with nothing. Did you want some of the cataract left? You only want to be partially sighted? You want it all out. So you see what we're doing here? Because we grooved it, we can crack it. Okay? So now we have 4 small pieces instead of 1 big piece. Okay? And what we're going to do now is we're going to emulsify these 4 quadrants. And we can do that much easier if we break it up. And as you see here, this tip with its cavitational and jackhammer-like effect is emulsifying this. And you see with this, we make sure that none of that comes up against the inner surface of the cornea. We're holding it down away from the cornea, okay? And here you see we're going to elevate that quadrant and grab it at its base. This has got aspiration, so it's got suction. It's got vacuum to pull this out of the eye. And it also emulsifies, and it wasn't cracked as well as it should have been. That's why that piece didn't mobilize, but I think we're going to get it now. Yeah. Okay, so we're going to bring it up again, and we're going to keep this on top, so we don't get nuclear sand or nuclear debris sandblasting the undersurface of the cornea, which would be detrimental to the cornea. Yes? Are you okay, kid? Good. I think we'll hire you as an assistant in the OR. You recover very fast. So again, this is the 3rd quadrant, okay? And we do it's very systematized, obviously. I mean, this is not something that is a haphazard endeavor. And we're breaking it up and actually removing it. And this process is called phacoemulsification. Phakos is the Greek word for lens, and emulsification is exactly what it says. It's being emulsified from a solid structure. Now, what's going to be left is a soft outer shell of the nucleus. The very outermost portion of the nucleus is soft compared to the central compact portion of the nucleus. And what you'll see is we're going to sort of trim that outer portion of the nucleus, the epinucleus, and flip it. And these are, again, surgical maneuvers that we've developed over the past 20 or 25 years. So we're trying to aspirate. You've got to be very careful, because if you pull the iris in, you can shred it. So, you've got to be very careful. You see, I get a little close to the iris, and that gives me a little bit of a rush. So what we're going to do here is we're going to aspirate the edge, and then after we trim it, we're going to flip it upside down, okay? And get it away from the bottom of the lens capsule, because if we break the lens capsule, the vitreous gel will come forward and a whole host of other problems can occur. So we're very careful to not break the lens capsule. So this is relatively delicate surgery. But this is all real time, and you're seeing what I saw in the microscope, except I had a 3D view. So here we're going to flip that portion of that outer shell. We're going to actually flip it upside down, And it breaks into 3 segments which really follow the anatomy of the lens. It follows the Y suture in the lens, but we will flip each of these segments. It's very stiff because this is an old cataract and it's gotten very hard. And this man who came back 12 years later and said he thought about it and he's ready actually started to cry when the surgery was over because he could see and he realized what he did to himself by delaying his surgery. And then what's left is going to be some cortex, and we're going to go in and strip out the cortex. Remember, the cortex is like the fruit in a plum, and it's a thin layer. It's not a thick layer like the fruit in a plum. And we're going to go in with an instrument like this, but not a vibrating tip. It just has an aspiration port, so with vacuum and suction, we will pull the cortex out of the eye. That's the bottom of the lens capsule, and now you see light being reflected from the surface of the retina, right? Like a camera, you know, when you take a picture with a flash bulb. Okay, so you can see. So now we're going to, I guess, I don't know if we showed the removal of the cortex or not. Now we're going to put the lens in. It's a rectangle that has an optic in the center. You got to watch because it's going to come out pretty fast. This is going to go right back in the lens capsule that the cataract came out of. And it's going to open pretty quick. There it is, starting to open. Can you see it? You see it? That's the lens that we're putting in the eye to take place of the power of the cataract that came out. Okay? And there's the optical portion of the lens, and that's the way the patient looked at the end of the operation. Okay? Yes? I'm sorry. What we put in? The question was that his own lens. No, that was an artificial lens. That was a silicone lens. But it's powered exactly for his ocular anatomy, for his length of eye and corneal curvature, because we can put in any power we want. Okay? Yes. How much time have we got? Okay, we've got to go get down the road. He saw 20/25 right away, almost perfectly. He started to cry because he realized what he did to himself. I mean, he came in with a white cane. Yes, yeah. How much could you see through that? Not too much. One question. Yeah. The capsule is connected by ligaments. And when we do that initial fluid injection called hydrodissection, we disconnect the lens from the capsule. So we're actually spinning the lens within the capsule. Does that make sense? One more question.
Hold the eye still in this surgery.
Why don't we hold the eye still? We're very busy. We have an instrument in one hand that's vibrating 40,000 times a second, another instrument in the other hand. We have a foot pedal that operates the phaco machine, and there are 3 or 4 positions in that foot pedal, and a microscope that has 6 positions on it, up, down, left, right. And so, you know, we got enough to do. But what we do is we make sure when 2 instruments are in the eye, the patient can't move. But we sometimes ask the patient to look in one direction or another to facilitate our own view of what it is we're trying to do. We don't have to poison or anesthetize the muscles that move the eye because it's a fast operation, it's painless, and it's to our advantage to have the patient able to move his eye to position it in ways that are helpful to us. Okay? Next. Oh, okay. All right. Now, we are in a new phase of eye surgery because we now don't wait for people to get cataracts. We have a new operation in addition to LASIK to correct refractive errors, and that is known as refractive lens exchange. So we now have technology that lets us take the human lens out and put an artificial lens in that corrects nearsightedness, farsightedness, astigmatism, and presbyopia, the ability to focus for near. Okay? So we're going to just show a couple of. This is a particular lens that we can put in that works by flexing. When the patient focuses, the lens flexes and moves forward in the eye. Okay? So he can focus for near. Does that make sense? So let's take a look at how. And these were studies done right here in Eugene, Oregon, showing that using an MRI, that with accommodative effort, there's a redistribution of ciliary body mass that pushes that lens forward. And this is an example of that lens going in the eye. It's not unlike the one that you saw, but you'll get a better view of the lens as it goes in here. See? And that's the way the lens looks in the eye. Now, when the patient's walking around with a normal pupil, what does his eye look like? Yours. Normal. Sure, you can't see that. You have to dilate it and look at it with a microscope. Okay, there are other styles of lenses. There are lenses that are like this that are called dual optic IOLs that have a plus lens in front and a minus lens in back. You know of any such thing? An instrument with a plus lens in the front and a minus lens in back? Yes, a Galilean telescope. So this enables a patient to read. Okay? And we have deformable optic IOLs. This is one, an IOL, an intraocular lens, that's what an IOL is, that has a fluid reservoir, and on accommodative effort or focusing on the part of the patient, fluid is pumped centrally, increasing the steepness and allowing for a more plus-powered lens and therefore an ability to read. Does that make sense? Sure. You're getting onto this, aren't you? Now, this is a fascinating new lens out of Herzliya, Israel. This is a lens that is based on principles found in nature, but this has the most potential for focusing of all lenses thus far. It has about 8 diopters of accommodation. I don't want to bore you with what that means, but what the hypothesis is that you need some ability to adjust for distance focus, about 3 diopters for reading, but we get eye strain symptoms when we read for a long time. So in order to have accommodative reserve, it has to have twice this, or 8 diopters. This is the only lens that has that. And it's based on the design, which has a soft, flexible polymer between 2 hard plates. The anterior plate has an aperture in it, so that on focusing by the patient or accommodative effort, this posterior plate is pushed forward and it forces this flexible polymer through the aperture, increasing the steepness, right? And therefore the power of the lens, yes? And so that allows for reading vision. And the thing that's fascinating about this is found in nature. Do you know what a merganser is? It's a bird that flies and is a diving fisherman. And the merganser, when it's flying, has a lens that looks like this. And it has an air-cornea interface for refractive purposes, but in water, the air-corneal interface is gone, right? So in order to increase the power of the eye so he can see in water, he can force his own lens through his constricted pupil to create an increase in power so he can see in the water, okay? And this is an example. This is the way he looks when he's flying, and this is the way the merganser looks when he's fishing in the water, okay? And this is an example of how that, this is an example of how that lens is going to work. So we take the lens out, we collapse the anterior and posterior capsule, we put that lens in, and we can see that with accommodative effort, we are able to change the curvature of that lens and therefore the plus power of the eye. Now, we also have some injectable polymers, and the most fascinating one is a polymer that is a thermodynamic material. It's a hydrophobic acrylic that is personalized and customized for each patient. It's designed to completely fill the lens. Now, you remember the other implants that you saw didn't fill the capsule. Is that correct? They sort of occupied the space, but not all of it. This is designed to fill a capsule. It is a stable gel at body temperature, but it is a firm lens at room temperature. It's thermodynamic, stable gel at body temperature. It can be converted to a rod at room temperature, and then when it's implanted in the eye, it reconstitutes to its original size, shape, and previously imprinted dioptric power, and because it's flexible, we will be able to focus. So this is a little bit of I'm going to just show you a little bit about it. This is the lens. It looks a lot like a human lens. It's called the Smart IOL, actually, not the Smart lens. That's at room temperature. It's convertible to a small rod. Remember, we take the lens out of the human eye through a small incision. Yes? 2.5 millimeters about. And look what happens under body temperature to that rod. Boom. Do you know, when I was an engineer, I was a polymer chemist. Polymer engineer. Do you see how this all fits in? Huh? So you see, it's very flexible. And since it's flexible, when the patient tries to accommodate, the lens will change shape, and he will be able to see up close. So we're going to have to move along here. Now, this is a fascinating new lens called Liquilens, and it's designed in such a way that the lens has within it 2 compartments. it's got a fluid below and a fluid above. See, here's below and here's above. And these fluids are immiscible. What does immiscible mean? What does immiscible mean? They won't mix like oil and water. Oil on water will just always stay on top. It won't go down, right? And if you turn, you can have one of the fluids fill the eye up to the level of the pupil and the other above it. And as you turn your head or your eye down, these fluids will shift. Is that correct? So more of the upper fluid will go into the visual axis, and since that's a high refractive index liquid, the power of the eye will increase. So you see here we got a low refractive index here and a high refractive index here, and looking in the distance, it's all going through this. Okay? And as we look down, we get more of the higher refractive index in the visual axis, and the patient can see up close. Okay? This is fabulous technology, isn't it? You don't think so? Okay, let's take a look at some of the things that we do to the retina. Now, you remember the retina is the inner coat of the eye. It exits the eye as the optic nerve, and that's where image formation takes place. So there are a couple of things that we'll talk about. One is diabetic retinopathy. Now, diabetic retinopathy is a very, very complicated process. Diabetes, in some ways, can be looked at not as a problem with sugar metabolism, but as a blood vessel disease with an associated sugar metabolism problem. Because you can biopsy capillaries and find diabetic changes before the patient is clinically diagnosed as a diabetic. And in diabetic retinopathy, we have a situation in which abnormal blood vessels grow in response to low oxygen tension in the retina. Do you know what hypoxia means? What is anoxia? No oxygen. Hypoxia is low oxygen. There are, within the eye, vascular endothelial growth factors. And in situations of low oxygen tension in the tissue, vascular endothelial growth factors can stimulate the growth of new blood vessels so that more blood can get to that tissue and deliver more oxygen. Does that make sense? Huh? Make sense? Yeah. Now, the problem with the blood vessels that grow as a result of hypoxia and stimulation by vascular endothelial growth factors is that they are abnormal blood vessels and they leak. And when they leak, blood goes into the vitreous, scarring takes place, inflammation takes place, and we can get an obliteration of normal retinal architecture and function. We can also get scarring of the vitreous and actually contraction of these scars that pull on the retina and detach it. So let's just take a look at some of the things that we can do. This is a diabetic patient, and he has just a couple of microaneurysms showing that there is trouble from diabetes. This is what a normal retina looks like. This is the optic nerve is over here, and this is the macula, the center of the retina, which is the portion of the retina that is most capable of good vision, okay? If you look at me, you're looking at me, but you see the table, you can see the sides over here, a little bit of the walls, maybe even a little bit of the ceiling, right? But if I said, what time is it? You have to turn your eyes so that the light from the watch falls on your macula. So these portions of the retina are capable of peripheral vision, which has a low acuity, and it's only right in here that we have good acuity, so we have to protect the macula. And if we get leakage under the macula and separate the rods and cones from their vascular supply, we're going to get into trouble. If we get bleeding in there and the architecture of the rods and cones are destroyed, we're going to get into trouble. A whole bunch of ways to get into trouble. So we can take this patient, it looks like they have very little trouble, and then inject a fluorescent dye into the arm and watch it circulate through the eye with a rapid photographic process, which has a system of baffles. There's a filter for the light going in and a filter for the light going out, so that as the dye goes through the eye, it fluoresces. And this will pinpoint for us what looks like a relatively benign retina can be seen to have a lot of pathology. These are all leaky microaneurysm. This is an early stage, it's 22 seconds. So what could we do to this retina to decrease the stimulus for new blood vessel growth. What can we do? Huh? Let me hear. Who said that? That's brilliant. How? Yeah. Big problem. But that's accurate. That would be one way. And of course, that's what the body's trying to do by neovascularization, growth of new blood vessels as a result of vascular endothelial stimuli. Any other thoughts? What can we do? Wisconsin, you got a way to treat this? Give me an outlandish way. Cut it off. Cut what off? Cut the eye off. That's great. You know, you can cure pneumonia if you put the patient in an oven. But the patient's husband is never happy. But you're partially right. One of the things that we could do here is we can kill some of the retina. Does that make sense? And therefore decrease its oxygen need. Does that make sense? And so this is really the basis for laser photocoagulation of diabetic retinopathy. We can actually photocoagulate the retina, kill portions of the retina, especially the periphery, which has less good acuity, decrease the oxygen need of the retina, and thereby protect the macula. And this is exactly what's done here. This is the macula here, and here, the periphery of the retina, all these white spots are scars created by laser. And this is a very efficacious way of treating it. We've reduced the oxygen demand of the retina. It turns off vascular endothelial growth factors. Patients can see for a long time and maybe forever as a result of that. So this is another alteration in anatomy. It's not one you're necessarily going to think of as your first choice, as to actually extirpate a portion of the retina, but it actually works well. Now, macular degeneration is a very large, diverse group of diseases that affect the center of the retina such that its ability to see well is gone. And there can be multiple ways in which the macula can deteriorate. There are so-called dry forms and wet forms. The dry forms are really abiatrophy. They come from death of receptor cells. The wet forms are based in some way or another on fluid or bleeding. But one of the new ways of treating it is with an implantable miniature telescope. So this is a lens that will allow the edges of the macula to work. Now we're putting this is a huge hunk of metal. It's a miniature telescope. We're not so concerned about small incisions here, are we? But what we're going to do is we're going to put this telescope in the eye, and it's big. It's 4 millimeters tall, and that's that molasses-like substance that protects ocular tissue and creates space. And the other incision that we made for the cataract, we didn't have to suture because it was small, but we're going to have to suture this one. You okay? So what we're going to do is we're going to put this in the eye, and this is going to enormously magnify the image that the patient is looking at. And it's been very helpful for a group of macular degeneration patients because they can see facial expressions when they communicate. That's a very important part of communication. Many of them can play bridge again. Some of them can read. And we only put it in one eye because it deprives them of the periphery of their vision. They lose their visual field. Okay? So you see, we have to be very careful because we don't want to scrape the inner surface. These are what the sutures look like. And then this is what the patient looks like sometime later after the sutures are taken out, I think. I guess we didn't include that in that video. Okay. Okay, that's it. So we got 5 minutes. So what you see is we have anatomy and physiology, and we very frequently use surgical modalities to either change the anatomy or the physiology in order to regain health or enhance function. Now, I'm going to have a question back there.
With the last procedure, since you're changing one eye but not the other, how does the brain interpret that? Does it cause problems focusing on things?
The question is, does it cause problems when you change one eye and not the other? It does cause problems. It causes big problems. A loss of periphery is important. Patients miss it. They have retinal rivalry because there's normal magnification in one eye and large magnification in the other eye, but patients learn to adjust to that. There's central nervous system processing that allows them to learn, and a lot of it is dependent on the motivation of the patient.
Can I ask you guys to settle down just for 2 more minutes so we can enjoy the last few questions?
Yes?
Thanks.
You said some of those artificial lenses can cure nearsighted, farsighted, some other things, including what you have. Why don't you get it?
Why don't I get it? Well, first of all, I can see perfectly like this. So unlike a patient with refractive error, when they put their glasses on, things are magnified or minified. The environment moves when they move their head. There are a whole lot of other concomitant optical aberrations that occur with glasses for them. I have none of that. But most importantly, glasses don't bother me. And so we tell patients, if glasses don't bother you, you shouldn't be getting refractive surgery. It's for patients for whom escape from glasses or contact lenses is important. Yes, in the back of the room. Yes?
What does your detached retina surgery do? I mean, how do you...
The retina detaches principally because a tear forms in it, usually with collapse of the vitreous gel on aging. And what we do is we create an adhesive choroiditis, an inflammation of the choroid under the hole, and then we buckle the sclera so that the sclera and choroid, the inflamed, sticky inflammation of the choroid touches the hole, and it seals the hole in that way. It's called a scleral buckle. There are other ways to do it, but we basically do it by sealing the hole. Yes? Yeah, the blue cap. Oh. Yeah, it's you. You were holding his hand up.
What is the life of those silicone discs before they break down into silica and silica dust?
Which discs? The implants, intraocular lenses?
Yeah.
They'll last a lot longer than you. They undergo accelerated aging studies, but there has been litigation involving who designed an implant before someone else, and cadavers have been dug up that have had them in their eyes for a long time, and there's nothing but a skull and good-looking implants in those eyes. Yes? Yeah?
The new contact lenses that they say allow oxygen into the eye, are those really that efficient?
They're a little more efficient than others. They allow for more oxygen. They're more permeable. They're not completely efficient, and they're not like exposing your cornea and your tear film to ambient air, but they're better. Yes? Well, there are a lot of factors that go into which eye you put it in. Usually it goes in the worst eye. It goes in the eye that has the most stable macular degeneration. It's not going to be efficacious because it's using perimacular tissue. It's creating an image in the tissue just surrounding the macula that is helpful. If there's an eye that has worse macular degeneration and it won't be beneficial, we don't do that. This is the first attempt at a whole new series of macular degeneration devices, but we go through a long process of evaluating patients' suitability for it, both anatomically and psychologically, and then we choose what we hope is the better eye to put it in. Usually not unless the degeneration is equal. Other questions? Yes? Why? It has to do with pigment. Why are some people heavily pigmented and others less heavily pigmented? All iris colors are based on the density of the brown pigment on the inner surface of the iris, on the iris epithelium. Yes? It's nice also. Yes? Orthokeratology is the branch of contact lens science in which the cornea is purposefully warped at night while you're sleeping so that your refractive error while you're awake is better and you can walk around without them. And that has not worked out well in anybody's hands. It's not good to sleep with contact lenses on. You get more oxygen by walking around with your eyes open than you do sleeping. So we don't ever do orthokeratology. Yes?
What is scleroderma?
Scleroderma really is not an eye disease as such. It's a skin disease, and it's a systemic disease characterized by thickening and hardening of the skin itself. Sclera is not, I don't know how that got in there. I didn't do it. Yes. No, he asked, is the laser that we use for shaping the cornea during LASIK damaging to the retina? Zero. No damage. Thank you very much.